Good morning, everyone. Today I'm going to give a presentation on the progress report on preconceptional, gestational, and postpartum carbohydrate metabolic disorders. My name is Dorina Greff. I'm a resident doctor at the Department of Obstetrics and Gynecology, and my supervisors are Szabolcs and Eszter Horváth. My vision is to increase fertility and complication-free pregnancy rate, and my mission to achieve my vision by novel prevention strategies and improve carbohydrate metabolism in women. Currently, I'm working on 3 projects. 2 of them are meta-analysis, and we started to prepare a protocol of a randomized trial. In the first meta-analysis, we are going to investigate efficacy and safety of inositols and metformin in the treatment of polycystic ovary syndrome. Polycystic ovary syndrome is one of the leading causes of infertility. The global prevalence of PCOS is 5 to 20%. The main characteristics of this disorder are polycystic ovary morphology and ultrasound examination, hyperandrogenism, and ovulatory dysfunction. Up to 60% of women with PCOS are also overweight. The pathogenesis of this disorder is still poorly unknown. However, insulin resistance was shown to have a crucial role in its pathogenesis. Systematic and local ovarian insulin resistance presents in 75% of lean and 95% of obese women with PCOS. An evidence-based therapy to treat insulin resistance is metformin. However, it has some gastrointestinal side effects, such as bloating, diarrhea, nausea, and vomiting. That's why another medical option is needed, which can be inositol. Inositol is a dietary supplement which belongs to vitamin B group complex. And according to an Australian guideline, inositol can currently be considered as a complementary therapy in PCOS with emerging evidence on efficacy, highlighting the need for further research. That's why our aim to examine the potential beneficial effect of inositols in the treatment of PCOS. Our clinical question is that inositols are efficient and safe in the treatment of PCOS. Patients are women with PCOS, our intervention is inositol, comparators are metformin or placebo, and our primary outcomes are presence of ovulation and cycle length. The secondary outcomes are BMI, pregnancy rate, carbohydrate metabolism, clinical and laboratory hyperandrogenism, and side effects. Our hypothesis is that inositols are non-inferior compared to metformin regarding the presence of ovulation and cycle length. Our clinical implication is to improve quality of ovulation or replace or complete metformin therapy in the treatment of PCOS patients. Hopefully, with our meta-analysis, inositol can be reconsidered as an evidence-based therapy. We conducted the systematic search in 3 databases at the 20th of October with the search key you can see on the slide. Now we are at the phase of data extraction, and we plan to finish it in 2 weeks. In the second meta-analysis, we are going to investigate the efficacy and safety of inositol in the prevention of gestational diabetes mellitus in pregnant women. Gestational diabetes mellitus affects 7% of pregnancies globally. It can cause several maternal and offspring complications, such as macrosomia, you can see on the picture, birth injury, higher C-section rate, and in long term for the mother has a 10-fold higher risk for developing type 2 diabetes mellitus, and have 2-fold higher risk for developing cardiovascular events in 10 years postpartum. Despite of these facts, there's no medical treatment is generally prescribed for the prevention of GDM. In the last year, several studies have investigated the potential beneficial effect of inositols. However, the body of evidence was poor. That's why our aim to investigate the preventive effect of inositols in the development of GDM. Can inositol treatment prevent the development of GDM in pregnant women? Our patients are pregnant women. Intervention is inositol. Comparators are no intervention or placebo. And our primary outcome is the GDM diagnosis by the time of oral glucose tolerance test. Our secondary outcomes are need for insulin treatment, results of OGTT, and maternal and fetal complications listed on the slide. Our hypothesis is that inositol can decrease the incidence of GDM compared to placebo or no intervention at all. Our clinical implication to improve dietary supplements for pregnancy. We conducted a systematic search in the 3 databases on the 5th of November. And we finished the full text selection, and now we have started the data extraction too. Our third project is based on our second meta-analysis with the title of Inositols and Dietary Fiber in the Prevention of Gestational Diabetes mellitus. The main strategy for managing GDM is dietary advice. However, it is unclear what type of advice is the best. Not just inositols, but also dietary fibers are shown to increase insulin sensitivity. Moreover, dietary fiber might slow down glucose absorption and lowers glucose and insulin levels. That's why our aim to investigate the preventive effect of inositols and dietary fiber in the development of GDM in high-risk pregnant women. The clinical question is that can inositol treatment and dietary fiber prevent the development of GDM in pregnant women? Our patients are pregnant women, and we are going to randomize the population into 4 groups. In intervention 1, they would receive inositol. Intervention 2, they would receive just dietary fiber. In intervention 3, dietary fiber plus inositol. And in intervention 3, they would receive just placebo beside basic nutritional support. Our outcomes are perfectly the same as I mentioned in the second meta-analysis. Our hypothesis is that inositols and dietary fiber supplementation started from the first trimester can decrease the incidence of GDM in high-risk pregnancies. Our clinical implication to improve dietary supplement recommendation in early pregnancy to reduce the incidence of GDM. Our specific goal is to submit our meta-analysis by the end of April and May, and hopefully we can start the enrollment of our patients by the end of May too. I would like to finish my presentation with a quote from Bill Gates. We all need people who give us feedback. That's how we improve. Thank you for your attention.
Thank you for the presentation. I'd just like to ask you, what do you mean at the last project by basic nutritional support? Would you provide them some supplements, or you would just give them some advice on how to?
It's just a basic dietary advice, have to eat well, if I can say that.
Okay, thank you.
About healthy foods. That's it. Thank you. Thank you for your question.
So about your last project, so this is what you plan. Can we go to your PICO? So you are forming actually 3 different groups. So what do you expect actually? I mean, on the combined treatment. Do you have any preliminary data, or is there anything in the literature that this kind of combination, I mean, has already been introduced?
Thank you for your valuable question. There's no data about the inositol and dietary fiber co-treatment, but we hope that this will be the most effective one, because managing GDM, right now we just can send patients to dietitian to have nutritional support, and with inositol we hope that we can increase insulin sensitivity too, and with dietary fibers too.
How do you plan to allocate people to the different groups? This may not be that easy, actually. This is a random design.
Yes, we would like to randomize that. Yeah. Yes, so this is our plan to randomize it.